Okay, I think it's time. So I think other members will join as we go along. But I want to welcome all of us who are already there. The headquarter team, you're welcome. I've seen, of course, Patricia and Winnie, our presenters are on. I've seen Nadine. Nadine, you're welcome. Nadine from DRC, you're very welcome. I've seen Frank from Kenya, very welcome. Yes, of course, Legese from headquarters, Limbikani, Mwetini. We will need you to actually help us to use the chat and click in a bit of your details. Some of us, we are maybe on a phone and we have not coded our presence. We see like the name of the phone and we can't tell who this is, but it will help us if you register through the chat and help us know, because eventually we want to be taking record of attendance. So you know your name, which country you come from, which organization, whether you're working with government or with a funding agency or with an implementing partner, and if possible, maybe what you do. You can do that, you can put that in the chat. There are people monitoring the chat to eventually draw the list of membership. And those of us, if you can, unless if your internet is not good, try as much as possible so that we can be able to see your faces. Otherwise, if we are not able to see you, we miss that interaction. But otherwise, I'm seeing so many members are joining in. I've seen Jutta has come in. I've seen the Atalanta headquarters team is on. I've seen Chipungu is also on. I'm seeing Mupanguri is on. Bruce is on. Yes, I'm seeing James from Malawi is also on. So I want to welcome everybody to this rather interesting session that we are going to have. The rest of the members will join us, but I think we form a good quorum for us to actually start our discussion. And for those of us who are at a hub where we have other members, it will also help us, like I'm seeing Nadine is having a team. It will be good that you register the team members so that we can be able to capture the attendance on the call. I have a few announcements to make before I invite our presenters, our subject matter experts who are already itching actually to start sharing with us what they have planned for us this afternoon and morning to some of us. Otherwise, I welcome all of you. So we have a few upcoming events. We have for next, during the International AIDS Conference in Amsterdam, that will be in July. On the 25th of July, we shall be having a dinner. The members who are going to be there, we encourage you to let us know. You can do that by sending us a message either on WhatsApp or you drop a mail to indicate that you are going to be there. We want as many of the member countries to actually attend the dinner. We would want a minimum, an average of 2 people per country. So if the country team members are not coming, but there are other country people who are coming, you could actually let us know. So we invite them on the dinner, such that our country, your country does not miss out on the dinner, because we will be sharing some interesting updates. Then we have another upcoming event, an interesting one that will come in October, around the 15th of October. where we are going to be, we are going to have a meeting, and it's going to be in Uganda, and we are going to be there to see the milestones, how far we have moved, and how things are, and how we are 1 year down the road since we launched October last year, what we have achieved, and what are we setting ourselves for in the next year. So you will be invited to be part of this meeting, planned around 15th of October. We encourage you to continue registering. You're helping us to register you. If you are not yet on WhatsApp, after this call, please drop me your phone number. Drop me your phone number so that I can register you on WhatsApp. I can give you my number if you don't have it. It's a +256 77 240 6862. So you can actually send me a message or a WhatsApp on that number so that we can invite you on the WhatsApp group so that we continue the discussion. Let us continue the discussion on the WhatsApp, and then and you can also indicate if you are going to be in Amsterdam during the conference. You can also send me a WhatsApp message. So I think with those few remarks, I would want to invite our subject matter experts this time around. This time around, we are having 2 subject matter experts. One, Patricia, from the International Laboratory Branch in Atlanta, very well versed in this initiative, the LARC project. The LARC project is trying to build, looking at the entire viral load cascade and looking at where weak areas are, coming up with innovations, working with country teams, developing quality improvement projects to strengthen the weak areas that they find in their viral load cascade. They have done a few projects around countries, and she will be giving us a bit of the background of the LARC project. But then we will have a case from Kenya that will be presented by Winnie, Shena, both of which are on the call. Are ready to start the sharing. So without taking a lot of time, I would want to invite them. Patricia, you're welcome, and Winnie, you're welcome. So I will request Nicholas to flash our slides.
Okay, thank you, Charles, and good morning, good afternoon, bonjour, Nadine in DRC, and it's a pleasure to be speaking with all of you. So my presentation will be describing an overview of the Laboratory African Regional Collaborative, or the acronym is referred to as LARC, and my colleague Winnie will specifically describe the Kenya LARC experience. Next slide. So by way of background, we have noted that while improvements have been made in HIV viral load testing, full integration of viral load testing and related patient management has not been fully realized. And while there is continuous quality improvement, courses and interventions at the lab and clinic level, but the question remains, are laboratory professionals and clinicians, and by clinicians, I'm also including the cadre of nurses, because in this capacity, they are functioning as clinicians. Are they together effectively functioning as a team, or are they working in silos? Also, to what extent is task sharing? And task sharing is defined as the process whereby mid-level healthcare professionals provide clinical services otherwise restricted to doctors. To what extent is task sharing fully understood and embraced at the health facility level? Also, to what extent are mid-level professionals who provide ART services fully aware of the importance of viral load testing and ensuring that these tests are appropriately initiated, that the specimens are appropriately collected and labeled, or that viral load tests are sought and used in patient management. Next slide. So the operational framework for LARC is the goal was to achieve and maintain HIV viral load suppression by improving the uptake of viral load testing through enhanced health systems and facility level capacity, including and focused on inter-cadre functioning, and to introduce an improvement culture whereby team members understand and routinely utilize quality improvement tools. The specific objective was to advance the understanding and awareness of HIV viral load processes within a specific health facility, to create the awareness of facility level bottlenecks that could impact the scale up of viral load, and to enable local intercadre teams comprised of health professionals, laboratorians, records professionals, to remediate systems barriers by introducing training in various approaches such as business process mapping, the capability maturity matrix, and other analytical tracking tools. Next slide. So we began the LARC project in 2016, and we worked within the 6 starred countries you see there. In East Africa, it was Kenya, Uganda, and Tanzania. And in Southern Africa, the countries included Malawi, Mozambique, and Swaziland. And again, we focused on addressing the communication and team building among specific facilities within these countries. And PEPFAR provided support to local teams to implement their specific intervention. Next slide. So as we look, many of you are familiar with the viral load cascade, but to review, there are 6 discrete steps: demand creation for testing, specimen collection and processing, sample transport, laboratory testing, result reporting and interpretation by the clinician, and patient management. Next slide. And we asked each facility in the respective countries to identify one particular aspect along the cascade most in need of improvement. And as you can see, the focus of these interventions occurred at the front end with demand creation, or at the tail end of the cascade with results reporting and patient management. And in those little boxes, you can see Mozambique and Malawi focused on demand creation, whereas Kenya, Swaziland, Tanzania, and Uganda, they focused on the result reporting and patient management. Next slide. So just briefly, this Makaranga District Hospital is a facility outside Dar es Salaam in Tanzania. And the facility, the intervention occurred in the care and treatment clinic at this district hospital. Next slide. So as a result of working together as a team, and on the left, you'll see a photograph of the team that included the records, the laboratory, the nurses at this particular facility. And their focus was on following up patients with high viral load. And with the skills we taught, we explained that you really didn't need sophisticated equipment to measure your impact. And here you can see on a blue board, the team began documenting over a period of 5 to 6 months where they were at baseline and what the improvements were and the percentages of how the follow-up was occurring. Next slide. Seeing more clearly on this run chart, and you can see on the left, on the y-axis, you can see the percentages, and the x-axis, the month of October, all that was measured all the way through February. And at the beginning, the follow-up of patients with high viral load by phone call was at 0 in October. By February, it had risen to close to 100%. And with those patients who were resistant with their viral load, they were followed up not only with a phone call, but also with enhanced adherence counseling. And that rose from 35% up to 96%. Next slide. So as a summary, the focus of LARC is to look at the lab-clinic interface by working with local facility-based teams comprised of laboratorians, nurses, doctors, medical records staff in 6 countries. Over the course of 1.5 years, Each team acquired health systems and quality improvement skills that involved both the lab and the clinic units. The training was reinforced through facility site visits and regionally convened learning sessions. We convened 3 learning sessions where each country team would provide routine updates of their project activity. And I can say that every country team, regardless of the level of facility or the country, or even the selected area of intervention along the viral load cascade, demonstrated significant improvement from baseline measurement. And our next step with LARC is to scale up the success and lessons learned from a facility level to a nationwide scale-up approach, which we'll do in Kenya. So now I'm going to turn the presentation over to my colleague, Winnie Shena.
Thank you. Thank you, Patricia. Good morning, everybody. Good afternoon. I'm going to present on the Kenyan experience, and going straight into my presentation, this is a picture of Homabay County where the project was done. You can see the Lake Victoria overlooking the town. Next slide, please. Now, I want to also recognize the 2 gentlemen on the right of the slide. To the left is Dr. Ernest, and to the right is Frank Basie, who are our lab advisors. And they did a splendid job in guiding the project through this process. Homabay is a high facility volume hospital, and it's one of the 5 HIV high burden counties targeted for ART saturation. It has all those beds and doctors and nurses. Of importance is that it has 7,103 ART patients on care and an average of about 200 patients daily on ART. It also functions as a viral load hub for other sites so that they collect and send to the testing lab. Next slide, please. This is the core LARC team. The first thing I'll say, you can see Dr. Makoha there. It is a mixture of nursing and lab. We had the lab leads from the reference lab, the CDC. We had nursing leaders from the regulation to the Ministry of Health, to the university, to the society. The most important thing about LARC and what we did as a Kenyan team is be able to choose a reliable team whose members touch on the process of interest. Then consider the members' expertise and ensure that you have a lab and a clinician interface. And there must be an oversight or a technical assistance. In our case, Dr. Ernest worked as our oversight or our lab oversight supervisor in Kenya, while Patricia was coming from outside. There must also be an establishment of a local team, which includes the implementing partners for ownership. Next slide, please. This is the local team. We had a local team that was consisting of the team, the lab manager, the nursing officer in charge, the nurses from the patient service center, the records persons, and the implementing partners who are working with us at that point in time. Next slide. So one of the quality improvement tools that Patricia had talked about is called business process mapping. And this is what I've just summarized the head of the slide and said that if you cannot describe your work process, then you cannot improve it or change it. And business process mapping is just a tool that you use to describe your workflow processes to be able to identify what are the gaps that are available. You can be able to do more than one. In our case, we did, I think, 3 business process maps so that we can be able to come up with a real problem. Among the first gaps that we identified was in specimen collection, even though when we did the second BPM, it was not the case. The second one or the third one actually gave us the results, which were delayed results of viral load for up to 1 month before being filed in the patient's charts from prompt care. What we noted from all this is that the first and the second business process map did not involve all the key stakeholders. So the point to take home is when we are employing the quality improvement tools, then we need to involve all the key stakeholders, and this includes the implementing partners on site who are also supporting in the viral load cascade. The second takeaway home is that do not make assumption on what the real problem is. Next slide, please. understanding the magnitude of the problem. So we had a problem, which was delayed results of viral load results of patients for up to 1 month. But we needed to know to what extent does this problem, or what is the magnitude of the problem. And for us to be able to determine this, then we had to collect data. And for us to collect data, we had to formulate a reliable and a simplified data collection tool, which we used to abstract information from the files. The other bit is that we had to think about the sample and the sample size. And we had also to plan how the data will be collected, who is going to collect the data, who is going to take charge, who is going to supervise, analyze, and how will it be presented. In the Kenyan case, we conveniently sampled 200 files, and we were able to document the presence or absence of the viral load tests that were done. And we were able to see the proportion of the files that were missing the present or the current viral load results in that month. Next. So this is an example of an abstraction tool. I may not go through it. This is what we used in that point in time. Next slide. So these are the results. What did we find out after abstracting 200 or 190 files? We found out that 96% of the files did not have the viral load results filed for the patients who are coming to be seen during that month. And so this one constituted our problem. And so we had to sit down and come up with an intervention of addressing this problem. Next slide. So this is what we did. We defined, this is another tool that you use. You have to define what your project is, and you have to go through some few elements that I'll describe, so that these are the steps that we took towards improvement. One, we had a problem. We defined our problem as hard copy viral load results for patients on ART were missing in the files. At least 96% of them were missing. When we looked at the measure, how big or how small is this problem, it was 96%. When we analyze through process mapping to understand the gaps, I will show you other tools that we use to analyze and to come up with a deeper understanding of what are the bottlenecks that led to that problem. Then we look at improving. So what did we want to improve? We wanted to, by August 2017, at least to have 80% of the patient's file having their viral load results in them. And then, of course, we had to look at what else are we controlling. We are controlling the processes that we've set up from the beginning. Next slide. This was an outline of what we wanted to do. So our overall goal was to efficiently manage HIV viral load results. Our target was to achieve 80% of the viral load results in the patient's file by 20%. Among the processes was to identify barriers, to design an intervention to mitigate the barriers, and of course engage the team at hand. For our case, it is a LARC team in Homabay to be able to implement the interventions that will be designed at that point in time. Next slide. So this is a flow chart. Once we did the process mapping, this is what we mapped out. We mapped the client from the start all the way. When the client comes, where do they go? Who meets them? What do they do? So when we start from the start, the client comes, the viral load is ordered, we collect the blood, it's converted to plasma, the batch is created, you dispatch, it's tested, the results come back, they are received. But when you go to the patient's file, there was a gap, and that is why it's in red. The results have been received at the lab and they have been taken to the records department, but they are not in the patient's file. Next slide. We also used a fishbone diagram just to look at the causes and the effect. And we looked just to draw and see what could have resulted into all these problems. And when you look at the red, the areas that are circled in red, you could see that the viral load results not reviewed and placed in patient's file. You could also see at the lab, we were losing a few patients on sample collection, viral load results not sent to the clinic, but those are just a few. But our biggest problem is that we did not have the results where they are meant to be. Next slide, please. So what did we want to improve? At the end of the day, we had a cause. What are the bottlenecks? We had identified what the bottleneck was. We did not have files, patients' results in the file. So what is it that we were looking out to improve? One was the intercadre collaborative or collaboration. We discovered that the lab personnel had done a splendid job in, mapping out their processes, and there was quality assurance all through in all the steps that we had gone through. However, there was a big gap between communication. There was a communication gap between the lab, the records personnel, and the clinician. The clinicians were blaming the lab for delayed results. The lab were blaming the clinicians for losing the patient's results. So there was this back and forth, and nobody could be able to understand what were there. So the first thing was to create an intercadre collaboration team. The second one was to design interventions that are easily implementable by the LARC team on site. The interventions did not have to be very expensive. They did not have to use a lot of resources, but an intervention that the personnel on the ground can take ownership and can be able to do on a day-to-day basis. One of the interventions they did was to identify a register to record the results when they come back from the lab, and get a dedicated personnel at the registry to be able to record all the results in the patient's file, or actually file them, not even recording, just filing the patient's results in the file. The other intervention we had instituted is just convening a regular meeting with the local LARC team to include the implementing partners, just to identify bottlenecks so that we can design and redesign intervention, and of course monitor the progress through analyzing data on a monthly basis. Next slide. The other improvement was to synergize and maximize on partners' contribution. We realized there were partners on the ground, they were doing a lot of good work, and it was imperative for us to be able to synergize and maximize on their contributions at that level, so that they can also be part and parcel of this intervention. Next slide. Next slide. Yes. Now, as we were improving, this is called, we were able to abstract data on a monthly basis. And therefore, the moment we had set a target, you can see we had written a baseline, 4%, that is our target. So we had only 4% of patients' results in their files back in October 2016. And we set a target of 80. Where the red line passes, you can see that is 80%. And with the recording of the patient's results in the file, and ensuring we had a dedicated personnel, we wanted to see what progress are we making over time, as this run chart shows. So in November, there was a regional problem where the results were all not available. And so that is why there was a dip of 0%. But in December, everything resumed its normalcy. And we were able to achieve an improvement from 4% to actually from 0% to 69.5%. And subsequently, over the months, there was subsequent improvement to ensure that patients' files had results, current results in them. When you see a dip of red, there was a strike by healthcare workers, and these are some of the confounding factors that we did not have any control over. So even as you're instituting your quality assurance, quality improvement projects, there are other factors that will still affect your project that may not really be under your control. By March and April, our percentages were high, even as we continued abstracting data. And by April now, we were almost achieving our 80% target. Next. At the end of the day, when we mapped out again to see where we were able to actually, from the value load results received, we were able to see that we had a dedicated person in red when we mapped out the entire process since the results are received at the patient service center. You can see in red that there's a dedicated person in the clinic to receive and sort the results. Those with very high viral load and those with, they are actually entered, their results are entered, they are filed, and the ones with high are called because these are high-risk patients. So there's a system to ensure that they come back on time or come back as early as possible so that they can be put on care and treatment, or they can actually review what is the issue with their treatment. The ones with low, it's still entered and they are filed, and there's a protocol between high and low low viral load patients. At the end of the results, we had a new process for filing of results. There was no individual dedicated at the clinic to receive the results. But by the time we were completing this process flow, we had a dedicated person and we had a register that ensured that when these results are received, they are actually filed and somebody actually is in charge of them. Next. To provide feedback to the facility, improve on documentation and management. We were able to improve interdepartmental communication. This is the LARC team at the national office, some of the members of the LARC team at the national office or the HQ team. And we used to make bi-monthly visits to the site to review data with the facility, to give them feedback and to just see how is it they are going on. Is there any gap they are facing, or is there any problem they're encountering? And then of course, the other measure that we had to control is that local LARC team was convening regular meetings to share information between themselves, and therefore we had, removed this barrier between lab and clinical staff, such that there was now a team that was meeting regularly to discuss any other additional problem that they encountered apart from what we had identified as a gap. And of course, this team is the one that was in charge to implement action plans and corrective measures on a timely basis. Next slide. Thank you so much. That was my presentation. Thank you so much.
Charles, you have to unmute.
Unmute. Okay. Okay, thank you very much, Patricia and Winnie. That was very, very informative and a great experience that can be handy for most country programs to use a similar approach. And you've managed the time very well. This is very good that we now have about some 25 to 27 minutes for interaction, for us to react, to ask questions to the group. So I would request that we react if there are any questions that have been sent through the chat. Shall read them out. But if you have any questions, please do. This is time now to react back to the presenters.
Hi, Charles, it's Bruce. You've got a couple of questions in the chat. You may want to take a look at those.
Yes, let's.
Looks like Nora Berry from Zimbabwe had the first question.
Nora. Okay. So I'm seeing, okay. Do you, I think, Bruce, can you read out the questions?
Sure, yes. So Nora from Zimbabwe asks, how do countries join in the program? And then Pascal asks, what's the best choice of staff to be assigned to the task? Lab staff or clinic staff or both? And then the LARC team in Atlanta asked if the site continued to track the measures to date, and if the register will be used at the national level.
Okay.
Okay, so I can address the first question. The first question is, when we initially began the intervention, we identified 6 countries which PEPFAR had identified as high priority for viral load scale up. So it was a demonstration project to see if the integrated team approach worked with training these teams on health systems tools on the Institute for Healthcare Improvement. So we had funding to launch this intervention for a year and a half based on the results that we were able to demonstrate. And we did not have sufficient time to show all the results from all 6 countries. We then received funding this year to select one country to provide national scale up. And we had, because we only could scale this up in one country, we selected Kenya. So the intent is that some of the tools that we have, we've developed into a workbook, which we have made available to ASLM, and we can make available to other colleagues of the workbook. And also, if countries are interested, we can provide remote assistance through webinar. Unfortunately, we don't have the resources to provide the in-depth in-country training that we did with our initial pilot. And with regards to the team, and I'll let Winnie also weigh in on this question, I think it's very important for team composition to have representatives from each cadre of your health facility. What I have observed is that there are CQI interventions that are taught for laboratorians, or CQI that's introduced in care and treatment, but it's unusual to see them brought together and to work and function as a team. And we really are stressing the strength of the interdisciplinary strength when you work together as a team and understand the flow, the patient flow from collection of specimen all the way through to filing in the patient chart. And that's developing that teamwork and back and forth. I mean, even in Homabay, and Winnie can respond to this, the clinicians thought that the laboratorians were actually processing the viral load results within the lab. And at that time, they were actually sending the specimens over to a reference lab, which was about an hour and a half away. So not even fully understanding how the specimens are processed is key. And this is just one example why it's so important to bring together small groups of your implementers at your facility. But Winnie, I'll let you weigh in on that issue.
Thank you so much for all your encouraging comments and questions. For the question that about the first question, I think Pascal has asked, what is the best choice of staff to be assigned to the task? In our situation, both from the HQ, that is the national team, and the site of intervention was the lab personnel. Both were the team leads for both areas. So at the Homabay, we had the lab manager who was the leader, and at the national, we also had Dr. Ernest, who was also our leader, and he's from the lab. But then the other bit is that that can be the person. I don't know whether I'm answering the question, or is staff assigned to the task. That means that whoever is assigned to this task depends on who is affected by the process. For example, if when you undertake your business process mapping and you map out your processes and you identify the gap as at the level of the clinical management of patients, then definitely you will have to include the clinicians and every other person who is affected or is a person of interest in that cascade. So that is how you recruit members of the staff or members to be in this team. There was another question. I think they keep going up very fast. Has the site, yes, somebody from Atlanta is asking, has the site continued to track the measure to date? The last time I asked them and I checked with them, they said yes, they still continue, though I did not get the specific data abstracted, because then we did not continue to abstract the data. But then I talked to the lab manager and he told me, yes, they are continuing with that process. And by the way, by the time we were finishing, the records department had also come on board. So we started as lab clinical, but then by the time we finished, it was lab clinical and the records department because of the issues of filing. Somebody is also asking, Nora Vere from Zimbabwe, how transferable were the lessons learned from this site to the rest of the facilities. Now, we were not really able to transfer because of constraint in terms of resources. However, I think that is the reason why we are here, and we are still continuing to advocate for LARC, because it's a model of improvement. It's a model, really, that if you institute this simple quality improvement model, then it will be able to work in whichever capacity. Somebody had asked whether we are using the register nationally. The thing about LARC is that you must be able to address gaps that you've identified within that facility. So we may not be able to generalize and say, let us have a lab register for all, or results receiving register for all the sites. Depending on whether they do have or not, then they can be able to replicate that register. Thank you so much. I think I'll ask Pat to continue.
So, and what I would say is the challenge for us was, okay, you were able to demonstrate success in various facilities. Then how can you sustain this at a national level? In Kenya, there are thousands of sites that are doing viral load testing. How can you expand this? So our approach, beginning in June, we have begun an orientation with Kenya's implementing partners. So our approach this year is to train the implementing partners and their facilities on these tools. And we began introducing that with an orientation webinar, actually this week. We'll be going out in August to start to do a similar startup with the implementing partners that cover there are four key implementing partners that cover the Nairobi central area, the Rift Valley. There's another GIS covers the Nyanza area, the western area, and then AMREF covers the eastern area. So we've brought them in. We've developed this workbook, as I've mentioned, which is available to anyone. And the other thing I do want to say, we provided online subscriptions to the Institute for Healthcare Improvement. And the Institute for Healthcare Improvement has an online open school that provides modules on health systems. And there are 7 or 8 that are absolutely essential for understanding these concepts that we introduced. For example, the business process mapping, or the Ishikawa, the fishbone analysis, all these tools that help with diagnosing your bottleneck in your facility. So that we made those courses available, and we have asked our implementing partners and the participating facilities to go online and to take those courses. Each course is about 1 hour. So we're hoping that by introducing these simple components, that it will enable us to have a greater reach than what we had when we first piloted the intervention. And then we're also doing a follow-up webinar similar to what you're doing to provide off-site distance support. I see from Bruce, are the tools and materials available? Yes, we will make the workbook. I believe we've sent the workbook to Charles. If you would like, I can resend it. And I also can send the link to the Institute for Healthcare Improvement. And I should say that there are 30 courses that are available. We paid for a subscription for 500 people to participate in 6 countries. Actually, we also included the Democratic Republic of Congo, Angola, and Cameroon. We included them in this group subscription. But if you're interested, let me know, and I can talk to my contact at the Healthcare Institute for Healthcare Improvement at IHI to see if we can get you enrolled. But the courses are very instrumental in reinforcing the concepts that you see demonstrated in the PowerPoint.
I think I'll respond to a few more that I've seen. Is that okay? Is that okay, Charles?
Okay, fine.
All right.
So, okay.
All right. Okay.
Mm.
One had asked about what measures that were put in place for sustainability. And I think for us, having a local team that was self-propelled was one of the measures for sustainability, because then we were not always there to oversight the teams. So having a local team made up of local, the staffs that are working there, the in charge of the facility, the patients, the staffs who are working at the patient service center and the lab, made it sustainable, because then they would actually hold meetings during their time. They would decide that we are having this meeting at this time and we are coming up with this intervention. So it was easier for them to be able to sustain the project because it is low cost. There was no cost involved in having that team around. So that to us was one of the measures of sustainability. There's a question that was asking whether which cadre was assigned a dedicated person to file the results. I think this was just a support staff that was given that work just to file the results when they come, just filing the results. And this person was not really employed. He was redeployed. There was a staff already, but they had just to look at their staffing patterns and see where do they need this person, or where can we get this person from, and just redeploy them to this area that really needs somebody. And so it is not a very high qualified person, but at least someone who can be able to read and write. And so that is what this site. Thank you, Charles.
Seemed funding has been a challenge, and having started with 6 countries, and now your second year you zeroed in on 1 country. Can you give us an idea of how much it costs to run maybe one QI project? And if seeing that it is transformatory, why can't it be advocated that countries budget for it within their coags? I think you are muted, Patricia.
Yes, that's a good question. And that, in fact, is what we were told. We were told that if countries are interested in this activity, they can include it in their COP, in their country operational plan, as opposed to having headquarters provide that assistance. The main cost for us related to convening the meetings. For example, the facility in Kenya is in Homabay, and that's in the west. And we had a national team that was also in Nairobi. So some of the resources were involved in flying our team in Nairobi to Homabay on a routine basis so that they could begin working at the facility. Also, some of the other countries, for example, in Mozambique, we provided each country with a small amount of funds. We provided each facility $10,000. And we asked the teams to work together and decide what the priorities were based on their intervention. Some of the facilities purchased filing cabinets or boards like you saw in the presentation. There was a blue board where the teams were beginning to post their run charts, their results. So each particular country had a unique need, and we wanted to ensure that the resources weren't a rate limiting factor at that facility. I think for countries that are interested in this kind of approach, they might want to identify one particular facility that they can work with just to acquire the skills and to roll out an intervention in one site. And then they can begin looking at an approach that we are now, which is how do you scale this approach nationally? And that's why we're going to the implementing partners and using the webinars and the training and the workbook to see if we can accelerate the spread of these interventions. And I just think it was noteworthy that some of the facilities varied significantly. Some were very small, some were large. Homabay was seeing close to 200 patients a day, and yet every single facility showed significant improvement. So I do think, I think it's important to see that this is an intervention that is practical, adaptable, and it can be sustained once people understand how to identify bottlenecks and how to function as a team to address those bottlenecks. The other thing I would say is the subscription. If you wanted to have, for example, many more people in your country to take the IHI courses, it was $1,800 for 250 subscribers. So that again could come easily out of the country operational plan budget.
It's been quite interesting.
So Patricia, just a question, that's Pascal. So you say it's $1,800 to have like 250 participants, is that correct?
That is correct. And we paid for $3,600 and were granted 500 subscriptions to take the course.
Yeah. So is that, so like an organization like, for example, the LabCoP could think of having such a subscription so that the LabCoP members could also benefit from this course if enough LabCoP members would be interested?
Yes. And I want to say one other thing. There are 30 courses in the open school, the IHI open school. And after each course, and I want to say within a course, there's different lessons. When you complete one of these courses, you receive immediately continuing education credits, or CPDs, and you can download that to your computer and print it off. And I know in many countries, Kenya, for example, they require CPDs for relicensure. And I know nurses require 30 CPDs every 3 years for nursing licensure renewal. And I know physicians have the same requirement. So it's a way to get an immediate online certification of training at no cost. So it really not only introduces a new skill set, but it really enhances professional career development.
Do they receive a certificate?
Yes.
After the trainings?
Yes, after every course that you take, for example, if you take a course that's 1.5 hours, at the end of it, on your screen, it will say print off a certificate, and the certificate will have your name, and it will tell you exactly how many hours of continuing education credits you receive. So you automatically can print that off as soon as you complete the course. You need to complete there after each course. There's a quiz, and you need to score 80% or higher. Now, if you don't score 80%, you have to go and retake the course, but that's not difficult. You can review those areas that you did not score successfully. So everyone is able to receive a certificate if they put in the time to go through the course.
Yeah, and the 500 people that you paid for.
Yes.
Were they among those that participated in your first round, or you still have slots?
we have a few slots. And for example, I believe I met with Nadine last week, and for a few people who want to try it, let me know, and I can give you the access code, and you can go online. If you think that it's valuable for your country, then I would encourage you to go in and pay for a subscription so you can have more people from your country to take it.
This is Katie Yao in Atlanta. I want to share that I sent out a link to a page for the least developed countries on UN list. If your country is on that list, you get to access the IHI Open School for free.
Wow, that's good news. So we will check that out. I think the LabCoP members really need to take advantage of this. And where need be, like Dr. Pasco has said, I think the LabCoP project can pay for a few additional people. I think, Dr. Pasco, that could be possible.
Yeah, sure, that would be possible. This is why I asked the question. So please let us know if your countries would be interested, and if we really identify the need, we would be ready to support that.
Okay. Wow, that's great. Is there any other question? We seem to have had very good management of our discussion, of our time. We still have some 5 minutes. If there is anything burning regarding the discussion that we've had, I would greatly encourage the members to take advantage of these trainings, and let us check out all those lists, links that have been given, so that and then ASLM will be willing. LabCoP will be willing to support when you communicate.
Charles, I did want to say that it would be useful to check with us next year to see how our national scale up is, how successful we were in introducing this intervention to Kenya's implementing partners. It's one thing to do it at a facility level, one-on-one, but then to ramp this up to many facilities within a country is the next challenge. So I'm sure there will be lessons learned just on that process. So check back with us in about 6, 7, 8 months, and we will be happy to share that experience with the community of practice.
Okay. Maybe another question about the other 5 countries.
Yes.
That did not take on in the second phase. Checking out to see whether they are still implementing the projects they were doing in the first phase, because sustainability really needs us to mainstream, that people can do it within their regular framework. Is that happening, and do you have any feedback to that effect?
Yes, we have, and we, for example, recently, when I was in Tanzania, I revisited the clinic that I showed that slide, and they are still tracking the follow-up of the patients with high viral load. A couple of countries have contacted me, and they have said, can we use our funds and send 1 or 2 people from our countries to your Kenya learning sessions so that we can continue to remain engaged? So we have Swaziland and Uganda have expressed interest in sending a couple of individuals from their team back to the learning sessions that we will be convening in Kenya so that they can remain engaged. So to the extent that we have heard back from those countries, we shared also with the countries the workbook, we've given them the subscription to get to the online courses, and we also told them that we are available to work with them through webinar long distance assistance if it is needed. So we do remain in touch with the other facilities, and have heard that they are continuing to use the interventions at those sites that were introduced in the LARC 1.0 version.
Okay. Bishu, I think you're going to get a lot of requests and interests from the LabCoP team. So you will need your guidance on how to proceed. So if there are no more reactions from the teams, I would want maybe Dr. Pasco, is there anything you want to say on top of what I said at the start before we close out?
Thank you, Charles. I think just stressing, from all the participants here on the call, for those of you or people from the ministries that from your country that will attend IAS 2018, please let us know so that we can have our meeting on the 25th of July in Amsterdam. Just let us know. That would be very, very nice.
Pascal, can I just, I think you all can hear me. Pat, I just think that, you did such a great job with this LARC initiative in the multiple countries. It might be helpful to the group if you present one of the other interventions, before the 6 to 8 months is out, because it could be, it might be possible that some of the countries can take the examples of what you have done and apply them in their country context and scale up. So you might consider, you know, this is excellent. All of them actually were fantastic, but you might consider sharing one of the other country experiences, you know, sometime in the next few months.
Thank you, Shirley. We certainly can do that.
I think there's enough time slot for you to do that. So let's discuss this and let's see, you know, in the upcoming session, either in July or in the next few weeks, how we can organize this. And that would be great to hear what countries are doing. Maybe they are not using the LARC, but they are really trying to improve, you know, the lab clinical interface in their facilities. And we would be glad to hear about that.
Okay, thank you very much all. It's been quite a very interactive session, and I want to thank our subject matter experts who have been quite elaborate and very passionate and very eloquent as they shared the information for answering the questions. And I think the members have been satisfied with the responses that have come through. So let us see how we proceed. We will continue to need your help and be readily available whenever we call on you to give more guidance. So we want to thank everybody. I want to thank you, particularly all of you. You've used the chat very well this time around. Please keep it up. Keep it up. And those of you who have already sent in your numbers, we are beginning to put you on WhatsApp. If you are not yet on WhatsApp, please send your number. I've sent my number for you to use to send your number. Otherwise, thank you very much. We look forward to our next session. We will give you details as we go by on the dates and the topic of discussion. Just keep your ears on the wall and use WhatsApp to get all the updates. Thank you very much. Have a nice day.
Thank you, Charles.
Thank you, Charles.
Okay.
Thanks, Charles. Thanks, everyone.
Thanks, everyone. Yeah.
Thank you.